Good afternoon, everyone. Welcome back to our lecture series under the Department of Medicine, CMC. Today we have with us Dr. Anjana Joel. She is an Assistant Professor in the Department of Medical Oncology, CMC Vellore. This will be one of the last lectures with the Department of Medical Oncology. She'll be saying a big thanks to all of them for taking time out of their valuable time which is supposed to be spent with the patients. But I think we do benefit quite a lot from what they've been providing. To tell about ma'am, I think she is a CMC in terms of finished her MBBS and MD internal medicine from the from CMC Vellore, and had done a DM medical oncology from Cancer Institute, Adyar, Chennai. She also has finished, got the certification from ACMO, finished a DP and DPNB, and also had done a MRSP specialist certificate in medical oncology from Royal College of Physicians, UK. Ma'am is also affiliated to multiple professional affiliations in terms of being part of ISMPO, ASCO, ESMO, as all mentioned there. Ma'am is also a recipient of multiple awards, especially to mention the IACA Traveling Fellowship 2019 by the Indo-American Cancer Association. So, for following which, as a part of which she has been able to spend quite a time of having an experience in Cleveland Clinic. For which she has been exposed to having a training for the breast cancer. Ma'am has also been awarded the gold medal for best outgoing postgraduate in DM medical oncology by Cancer Institute of Chennai in 2017. She has multiple publications under her, more than 15 of them. She is one of the very approachable doctor that we have, and as a senior, she has been very cheerful and very friendly. Someone who can approach for any doubts and other things. I hope this session will be a very fruitful one to all of us. I think among all the cancers, as a physician, I think we mostly end up having facing malignancies which are of unknown origin. So this lecture is what we are all looking forward to. If any doubts, please feel free to drop down your questions or doubts in the chat box, which can be answered towards the end of the lecture. This lecture will soon be anyways uploaded on our Department of Medicine YouTube website. So thanks again to ma'am for having taking this time out for us. Over to you, ma'am.
Can I start? Sure. Okay. Good afternoon, everyone. I think you all can see the screen. So again, thanks to the Department of Medicine, and also thanks to you, Anju, for that really warm introduction. So I think this is the last topic as far as the oncology lectures go. And I think probably this is something that most medicine postgraduates encounter on a daily basis in as far as outpatient and inpatient goes. And this is how to approach a probable malignancy or a malignancy which is being diagnosed. And sometimes you often notice that these malignancies, you don't have a primary. So this is the approach to generally evaluation of most malignancies, I would say, that most of you would encounter. So this is the schema of my talk. So I will go on to define what an unknown primary is, and then how common that is, and also what is an unknown primary. I mean, does the primary really not exist? So a little bit on tumor biology, and what are the histological subtypes, and then how we approach some of these types and how we work them up. And then we will also touch upon things like immunohistochemistry, PET-CT, molecular profiling, and maybe a brief word on treatment. So when you want to define a cancer of an unknown primary, so this is a histologically proven metastatic tumor which is malignant, and where you cannot determine a primary despite a good pre-treatment evaluation. Now, what is a good pre-treatment evaluation? It is, I think most of our evaluations at least as far as the Department of Medicine goes, would come under this category. So people who've had a fairly good clinical history and physical examination, people who've been evaluated properly as far as the labs go, including say things like tumor markers and also their scans. And of course, they would have a biopsy which shows a metastatic tumor. When we look at the epidemiology, now how often do you encounter a situation where you have a metastatic malignancy where and you don't know where the primary is? the thing is, this actually traditionally has been a thing of the past, and most often these patients get diagnosed as far as in an autopsy. So if you talk to oncologists, say who were treating patients 20 years ago, this would have been much more common. So when we look at databases, the SEER database is one of the largest databases in the US. So the incidence is around 2 to 7%, and often it's frustrating to handle these patients. I mean, if you have been in a medicine ward, been a medicine registrar here, and you have a diagnosis of malignancy, and then you are still working up a patient, and you send across a consult saying we can't find a primary. Often it's frustrating for the person working up. It's frustrating more than that for the patient, and it's also frustrating when you want to make a treatment plan for this patient. So when you look at how you sort of approach patients with an unknown primary, remember, things are getting better with time. So especially when you look at how things in oncology have evolved after, say, 1980 till now. So when you look at the first decade, so remember, most treatments for solid tumors, as far as even chemotherapy goes, the big leap was actually made in the 1970s and the 1980s. So in that first decade of 1980 to 1990, at least you had fairly decent imaging. Some immunohistochemistry was coming. People would at least classify things into carcinoma, sarcoma, and lymphoma. And you had some access to chemotherapy, which was, again, it was more of taking a chemotherapy drug and sort of throwing it at whatever diagnosis of malignancy the patient had, rather than tailoring it. So the chemotherapy was also empirical. Then we went on to the 1990 to 2000, where imaging improved. And then we had bigger immunohistochemistries available, which would kind of help us to direct as to where this metastasis originated from, as to the tissue of origin. And then again, this treatment of empirical treatments continued. Okay. Then we moved on to the last decade. So this was 2000 to 2010, where again, we started getting more access to better imaging techniques, including a PET CT, which was more frequently available. Immunohistochemistry pretty much became the standard of care in most, at least tertiary level centers. There were molecular tests, or rather molecular markers for a lot of these cancers. Say, for example, in lung cancer, we kind of realized that an EGFR mutant lung cancer behaves better than somebody who doesn't have this mutation. And people, rather than doing an empirical treatment where you would just say, I have cyclophosphamide with me, I have cisplatin with me, I have etoposide, come, let me make a chemotherapy regimen and treat whatever X cancer. So other than that, people started tailoring treatments for cancer. So they looked at different mutations as far as each cancer goes and started tailoring treatments for that. And today, we are in the era of personalized medicine. Okay, so again, we are able to classify or diagnose tumors better. Our diagnostics skills have improved dramatically, and so a true tumor of an unknown primary actually is very rare. Okay, even in our setting. Now, it is probably of more relevance in India in a secondary level setting, or even in the primary level setting, where we do not have adequate access to things like immunohistochemistry or even a PET scan. So we will work around how to approach these patients. So this is again the 4 decades, like I told you. And also what has changed in the last decade is that we have better diagnostics, better therapeutics, even for patients with metastatic cancer. So even in metastatic colon cancer, lung, ovary, breast, and so on, we have new treatments. And I'm sure you've all heard about some of these new treatments, including immunotherapy, in the prior lectures. Now, how common is it in India? Again, in India, I think there is just one paper which is from Assam. Now, this is a cancer center which is not really that much of a high volume center, but it is still on the National Cancer Grid, and it's around 5% of all their cancer. So this was a data set which they looked at up to 2010. Now, again, like I said, a lot has changed after 2010, and I'm sure the incidence will be much lower even there. And the commonest sites of involvement were lymph nodes in 60% of patients, or patients presenting with liver metastasis was around 20, isolated bone disease and peritoneal disease was much lower. In CMC, I had the privilege of talking to some of my colleagues in the Department of Medicine, and I know that Josh, who worked with us, did a small retrospective analysis of around 70-odd patients who who were admitted under the Department of Medicine and who, as an inpatient, and underwent evaluation. And what was surprising is that in 10 out of 77 patients, actually the primary was not apparent. Now, this again is quite a high number. And this could probably just be attributed to the fact that we are a tertiary center and we do have a referral bias, and a lot of these more complicated patients do land up here. Now, as far as tumor biology, does it really exist? I mean, how can you have a tumor which is metastatic and you don't have a primary? Now, the most commonest explanation for this is often what is called a burnt out primary. So remember, in tumors which are very rapidly proliferating, often the primary can be burnt out, and this is very, very typical of a tumor called choriocarcinoma, which is often seen in the gonads, in testicular cancer. And then, of course, there is an occult primary, wherein the primary is too small. And there are a lot of theories where they say whether these metastases arise from rest cells, is there a genetic basis, or do these differentiate from stem cells? But the biological events that allow the primary to remain obscure after these mets develop it's not really very clear. And what is the most likely explanation are the first two, where a primary is either burnt out or it is just occult. Now, remember, when you have a very small primary, and even if you do a test, say, for example, if you have a tumor which is, say, you have lymph nodes in the neck, and you are looking to see whether you have a primary tumor anywhere in the head and neck with an NPL scope, you're looking at the nasopharynx. Sometimes you may not be able to sample that small primary which is there, and that is the reason why you're not picking it up. Or the primary is so small that even a PET scan is not able to pick it up. So the first two are the most likely explanations. Now, to an internist, so all of you are mostly medicine residents, and what are the likely clinical presentations? So this is what you all, I think, will encounter, and these are the kind of ways you would sort of encounter these patients. So most often you may see a patient who comes to you with say lymphadenopathy for evaluation. So these patients may either have cervical, inguinal, or axillary lymphadenopathy, or you may develop the patient who has disseminated osseous mets, who comes to you with features of bone marrow infiltration, say cytopenia, with say cytopenias or pancytopenia. You may have patients who just comes to you for evaluation of ascites and or pleural effusion or a non-resolving pneumonia. You may have patients who come with retroperitoneal masses, and also you may see patients who come with just a solitary CNS lesion, which of course goes on to be to be surgically addressed and then found to be a metastatic tumor. You may find metastatic melanoma. Now, metastatic melanoma you may find, say, in the lymph node, or you may find it in the bone marrow. I recollect a patient during my DM where this patient was a boy who came with multiple bone lesions. He was 22 years old, and he had again anemia. And I remember doing that bone marrow, and the aspirate was black in color, and I looked down and I could see one big nevus on his leg, and so sometimes melanoma does present like that. Metastatic neuroendocrine tumors also are typical. And for you in medicine, you may encounter patients who come with other things which are ominous and which would suggest that this patient can have an underlying malignancy. So a patient may come to you with paraneoplastic syndromes or thromboembolic episodes, and often you are the point of contact. Now, I would just highlight each of these presentations with a few cases. These are all our own patients who are being treated under us. So this is a 36-year-old lady. She's a never smoker. So she came to us first in 2016 with new onset seizures. Her MRI brain showed a solitary frontal SOL. So this was excised by our neurosurgery department, and everybody was surprised because this was reported as a metastatic carcinoma. Now, the immunohistochemistry, I will kind of explain this to you later, but essentially the TTF1 is thyroid transcription factor. This is expressed in tumors which originate from the lung or from the thyroid. So this was a metastatic lung cancer. And I think you would have heard enough about the molecular markers in lung cancer. So this lady was fortunate enough to have an ALK positive lung cancer. And so the moment we saw this, we did a PET scan to look for a primary, and surprisingly, her lung was normal. The rest of her body was actually perfectly normal. So we put her on a tablet called crizotinib, which is an ALK TKI. And so she's in remission at 5 years. So this is a patient who just presented with a solitary brain SOL. Now the next patient, this is again a patient we saw a couple of weeks ago. She was a 36-year-old lady who came to hematology first with anemia and bony pains. And she was actually referred from elsewhere saying acute leukemia. She had anemia and her peripheral picture actually showed a leukoerythroblastic picture. So they did a bone marrow biopsy, which showed a metastatic carcinoma. CK is cytokeratin. So cytokeratin is positive in any tumor which is of epithelial origin. And GATA3 is a breast marker. So the pathologist actually gave a suggestion that does this patient have a breast primary? So we went back, or rather the treating unit went back and looked at her again, and she did have a left breast lump. So she was diagnosed to have a metastatic breast cancer. And of course, we went on to characterize the breast cancer better by doing ER, PR, and HER2/neu. And she started chemotherapy and, of course, received radiation for her bone lesions. The next patient, this is again a patient who presented with a paraneoplastic syndrome. So sadly, this patient didn't come to us. He presented it to his GP back in another city. He's a 56-year-old male who was not a smoker. He was evaluated for polycythemia in 2018, and he very clearly states that he did undergo an ultrasound abdomen, which was normal. 2 years later, he comes with new onset back pain, and an MRI shows multiple bone lesions, and his CT showed a renal mass. So he actually had a metastatic kidney cancer, and the paraneoplastic polycythemia actually predated his diagnosis of a metastatic kidney cancer. Now, so what I initially talked to you was about the clinical approach of whatever syndromes, the clinical syndromes which they will come to you. The next approach is, of course, a histology-based approach, wherein you have evaluated a patient and you find tumor. Now, you can find tumor which is of different histological types. So when you look at cancer of an unknown primary, you can have the commonest one that you see is actually a carcinoma. So carcinomas, remember, are tumors of epithelial origin. Now, in carcinomas, you have a lot of subtypes. You can have the adenocarcinomas, which are tumors which arise from tissue which has glands. Then you have, again, the very difficult, poorly characterized tumors called the poorly differentiated carcinoma or adenocarcinomas. Then you may have the squamous types. You may have neuroendocrine carcinoma. And then remember what is PDMN is a poorly differentiated malignant neoplasm, wherein we know that it's not a carcinoma, it's not of epithelial origin. So then you have to look at other tissues of origin. So those will include patients with, say, hematopoietic involvement of the hematopoietic system. Those patients could have lymphomas, or even a chloroma, and a melanoma, or even a sarcoma. So when you look at these histological types, it is when you evaluate these patients, I think one of the things that our training here sort of has been a strength of our training here is the way we're taught from our teachers about the history and physical examination. I think as far as our patients go, our history and physical examination is pretty much thorough and focused. And the physical examination actually will also sometimes include things like a pelvic exam in women, and breast examination, and of course a digital rectal examination in a male, and sometimes even in women, and also an ENT examination in men. Sometimes examination of the testes also is important. Now, traditionally, these are the battery of tests which anybody would do when you see a patient wherein you see, you have metastatic lymph nodes, or somebody comes to you with a suspected malignancy. You look at that patient in OPD, and so you would want to order a complete blood count, a metabolic panel, including calcium, and an LDH. LDH is actually, it is not a specific tumor marker. It only indicates the amount of disease burden. And then, of course, at least a contrast-enhanced CT of the thorax, abdomen, pelvis. And then you have to be smart. So if you feel that this is a lady who's likely to have breast cancer, or if there is any histological indication that this patient could have breast cancer, a mammography, or if you have a man who's come to you with multiple bone mets, obviously a serum PSA would be indicated. Then, of course, your biopsy. So the take-home message here is that don't go slow on that biopsy, because that biopsy is essentially sometimes what will guide you as to where your primary could be. So you quickly do your CT, and then if you don't see an apparent primary, go ahead and do that biopsy, because remember, these things take time. And and for most of our patients, time is the limiting factor. Okay. Now, once you have a diagnosis of a metastatic malignancy, the next step is, of course, things like molecular testing and a PET CT and next generation sequencing. So I will tell you when you would order either of these or when you wouldn't. So when you look at histological types, when you look at adenocarcinoma of unknown primary, so this is the most commonest presentation of any cancer of with metastasis. So now again, the clinical presentation depends on where all it is involved. So for example, if you have a patient who has multiple liver mets, obviously you will think of a GI primary. This patient could even have a lung primary or a breast primary, and sometimes even a gynec primary. So your evaluation should be along those lines. When I say evaluation, it also includes your history, and your physical examination should be directed along those lines. Now, or if you have a patient with multiple lung mets, you could still have a lung primary, GI, gynec, GU, kidney cancer, and even sometimes things like thyroid cancer can present that way. Cervical lymphadenopathy, very easy. Lung, esophagus, stomach are some of the common sites. And intra-abdominal nodes, inguinal nodes, gynae, GI, and genitourinary primaries are what you would see. When you have ascites in a woman, again, CA125 and a gynae evaluation is important. And again, remember, in India, gastric cancer is quite common. So anybody presenting with ascites, a little bit of new-onset dyspepsia, you would be okay going ahead and getting the upper GI endoscopy done. And again, patients who come with multiple bone lesions, lung, prostate in a male, and also kidney, things like thyroid. And remember, there are some tumors which do present with de novo brain metastasis, like for example, lung cancer and kidney cancer. So if you do encounter those situations, it's important that you recollect. So your knowledge of the likelihood of either of these areas would actually direct how you evaluate these patients. Then when you look at squamous cell carcinomas, thankfully, unfortunately, these are not as common as adenocarcinomas. But the good thing is that, they usually present as mets to the cervical or inguinal lymph node areas. And these are actually called the favorable subsets of unknown primary cancers. The reason being, these respond to chemotherapy and radiation. So, you can make a difference with treatment in this subset of cancers. The other thing is, when you look at cervical adenopathy, when patients have squamous cell carcinomas, most patients will be middle-aged to elderly, and you would obviously see use of tobacco. Some of these may be EBV associated. And when you have patients with squamous cell carcinoma in the neck, again, evaluation of oropharynx, hypopharynx, nasopharynx, and of course your upper esophagus is important. And sometimes even bronchoscopy to rule out a lung primary. Remember, in India, squamous cell lung cancer is still quite prevalent, unlike the West, because we do have a significant proportion of our population still smoking. And you wouldn't be wrong if you go ahead and do a thoracic imaging and a bronchoscopy. Inguinal squamous cell carcinoma, the primary sites will be the vulva, vagina, cervix, rectum, and anal canal. So a digital rectal examination, proctoscopy, and gynae examination is a must. Then neuroendocrine tumors are also rare. They form less than 5% of unknown primaries. The good thing is that you have a subtype of neuroendocrine tumors which are well differentiated or low grade. Now, these tumors, remember, are not as malignant, and there are good treatment options for this. The other extreme would be a metastatic small cell carcinoma. So in these low grade neuroendocrine tumors, a DOTA PET CT sometimes may help identify primary. Sometimes when you have a metastatic carcinoid, you can do a TTF1 immunohistochemistry, which actually may point towards a bronchial origin. Remember, but it is specific and not sensitive. So just because it is negative, it doesn't mean that the primary is not in the bronchus. Then comes the most dreaded type, which is the poorly differentiated carcinoma, where the immunohistochemistry is not really contributory. And this is again around 1/3 of all unknown primary carcinomas. Around a third of this still comes into adenocarcinoma, but sadly, in these sort of patients, you would not be able to sort of get any idea as to the primary based on whatever information you have with your imaging and your biopsy. So I will tell you about how to approach patients who have these types of involvement. So I think I've sort of briefly told you. So when you look at patients with lymphadenopathy and adenocarcinoma, you look at where your tumor is from. So if the tumor is involving the cervical lymph nodes, you kind of know that it could be from the stomach or the esophagus or even the lung. And you would evaluate them along those lines. If you have axillary lymph nodes, cross-sectional imaging of the thorax and abdomen is a must. If you have a woman with axillary lymph nodes, the breast has to be evaluated, ideally with a mammogram. And if a mammogram is negative, a breast MR, you would not be wrong if you do a breast MRI. But I would suggest that even before you do that breast MRI, you would biopsy that lymph node. And if it's in favor of a breast primary, you would end up referring to us and we would just get the MRI anyway. In men, even if you have cervical axillary lymph nodes, you would not be wrong in ordering a PSA and also going ahead with the cross-sectional imaging. When you have an adenocarcinoma with, say, thoracic, which is say with mediastinal involvement or with multiple lung nodules or a pleural effusion. Now this becomes slightly complicated because you can have different primaries. Remember, in males, if you have a young patient who has a mediastinal mass or even multiple mediastinal nodes, parenchymal lung nodules, do not forget germ cell tumors. You will have to examine the testis. You can send basic tumor markers, LDH, beta HCG, and AFP. And in a woman with this sort of presentation with pleural effusion, a CA-125 definitely is warranted. Okay. And when you have ascites in female patients, again, gynae examination, CA-125 is warranted. And of course, if that is negative, your cross-sectional imaging and looking at the gastrointestinal tract would also be relevant. Yeah, so when you have, again, distant metastasis, which is like extensive disease, multiple bone, brain, liver lesions, more often than not, these tumors are quite advanced and you would often find a primary. So by the time you organize a cross-sectional imaging in these patients, most of the time we would find a primary because these tumors are quite metastatic. When you have squamous cell tumors, again, remember those subsites that I told you, cervical and inguinal, and sometimes the axilla may be involved. And when we see a squamous cell carcinoma with a head and neck primary, for us it becomes a favorable subsite because we kind of know that most of the time these patients have a occult primary in the head and neck, and we often treat these patients with a curative intent. When you have carcinoma in the cervical lymph nodes, the other site which you often need to evaluate if you don't find a primary is the thyroid. So, sending a thyroglobulin and, even asking for a stain on the biopsy is acceptable. Then we will move on to immunohistochemistry. So often I get calls from medicine PG saying, ma'am, the preliminary report is this, what is the next step that we should do? So this again is a battery of immunohistochemistry, but what I'd like to just sort of highlight and tell you guys is you will encounter most common malignancies that you will encounter when you're working up are lung, breast, prostate, colorectal, maybe some ovary, and maybe kidney. So that is what I will focus on. So remember, for a lung cancer, most of these lung cancers, it is all actually based on your origin. So lung cancer is foregut origin. So you will get a CK7 which is positive, which is common to both lung and your upper GI tract. So stomach cancer and lung cancer will be CK7 positive. CK20, now CK, if somebody has joined late, CK is cytokeratin, okay? Pan cytokeratin just shows you epithelial origin. CK7 is specific to upper GI or foregut tumors. CK20 is for the other end. So it is for colorectal tumors. And TTF1 is again is positive with lung and also with thyroid. For lung, I'm sorry, I have not put one more marker, something called napsin. Okay, so these are the common immunohistochemistries which are done mostly when you are evaluating a patient with suspected lung cancer. In lung, remember you have adeno and you have small cell lung cancer. In small cell lung cancer, any neuroendocrine marker like chromogranin, synaptophysin, CD56, all those will be positive. So when you have colorectal tumors, remember CK7 is an upper GI thing. So that will be negative. CK20 will be positive. And there is also another marker which is more specific for colorectal, that is called a CDX2. For breast, Again, remember breast also will be positive for CK7. So there are a couple of other immunohistochemistry which the pathologists here do called GCDFP and also called GATA3, which will be positive in a mammary origin tumor. And we also have ER positivity, estrogen receptor positivity. But remember, some breast cancers can be ER negative. That's a setting where your GATA3 and your GCDFP will help. Prostate, PSA staining the tumor, unless it's a very poorly differentiated tumor, the tumor will nicely show PSA staining, and that itself is enough. For ovary, there are two markers other than CK7. Some ovarian cancers may also be ER positive, but that is non-specific. You can get WT1 and also something called PAX8, which may be positive in ovarian tumors. The markers for melanoma are pretty standard. You see that sort of a profile, melan-A and HMB45 positive, it cannot be anything else. And of course, kidney and so on. So, I mean, for a medicine registrar point of view, I think the first few is what is more relevant for you all. And anything else which comes beyond that, ultimately, I think you will end up asking for a consult from us and we will probably take over from that. And remember, for those of you who are working here, all this is done in CMC. So don't worry about access. But when you leave CMC and when you go out, that is where the difficulty is, because most hospitals don't have access to this. And you may end up spending a lot of time sending these reports and waiting for the results to come. Now, everything has its limitations. IHC, remember, like I said, the technical expertise is important. So in CMC, that is not an issue. You may have inter and intra-absorber variability. And remember, tumor heterogeneity can be a problem. So when you biopsy a big tumor from one end, that end may be positive for some IHC marker. The other end, the tumor may be negative. Tissue is always an issue. So sometimes tissue may be inadequate. And of course, you can have false positive, false negative results. Then we move on to molecular testing. So like I told you, this is the era of personalized medicine. So for lung cancer, we have a whole battery of tests. So if I have a patient with cervical nodes, whom I'm thinking the immunohistochemistry is more in favor of a lung primary, I will go ahead and order these molecular tests. Same thing for somebody who comes with multiple liver mets. I will go and order the markers for colorectal cancer. So I'll show you a patient who we treated. Some of you actually may know because this patient was evaluated first under medicine. Subsequently, he came to us. So he's a 42-year-old pediatrician who was fit. He was cycling every day 10 kilometers. Just 1 month history of bone pains, and he had multiple vertebral lesions. And he came here. He had a bone marrow biopsy which showed metastatic adenocarcinoma. So the medicine registrar sent the PSA. The PSA was normal while awaiting the immunohistochemistry, and the immunohistochemistry actually showed what looked like a lower GI primary. So the upper GI markers were negative, CK20 and CDX2 were positive. So then we had to get a colonoscopy done. And so the colonoscopy showed a 5 millimeter ulcer in the colon, in the hepatic flexure. So when I spoke to the person doing the colonoscopy, he said, if I hadn't seen that immunohistochemistry, I would have just discounted that ulcer. And that ulcer was biopsied. And this patient actually had a very fulminant course, and he deteriorated and passed away within 3 months. And we had sent a next generation sequencing for him, which we kind of got very late. And that actually showed this thing called a BRAF mutation. Now, BRAF mutant colon cancer with de novo metastasis is like really, really difficult to treat, and they don't respond to treatment. And that could actually explain why this patient had such a fulminant presentation and presented with such an advanced picture. Then there are some tumors where things like karyotyping might help, and especially things like desmoplastic round cell tumor, Ewing's, and of course germ cell tumor. Sometimes if you have a midline tumor wherein you can't characterize it, the isochromosome 12p actually can give you a clue as to this is of a germ cell or a gonadal origin. Then, of course, this is the most important thing. This is what everybody wants to know. When would you order a PET? So I think now most of us end up using PET in patients who present with, say, what is like a favorable subsite. So mostly squamous cell lymph nodes of the neck. Without a primary, we order a PET. Or if we suspect lung cancer, we order a PET. And any metastatic tumor which just has one site of metastasis, this is very important for us because that determines our intent of treatment. So if you have, even if you have a solitary brain lesion and your PET is okay, you would still go ahead and resect that with a curative intent. Apart from this, your PET will help you guide your biopsy It determines the extent of disease. It can facilitate planning of radiation. And then remember, you have to monitor these patients while they are on treatment or if they finish treatment. And some of these, and also remember, patients who have renal dysfunction you can actually get a PET done. And now there is also some data that things like whole body MRI also can be done. I think we do have a couple of trials here, which are prospective studies going on in CMC where they are evaluating whole body MRI in some metastatic cancers. Now, the other question which everybody has is, so what? I mean, it's an expensive investigation. Everybody has to pay for 30,000 for this test. Does it really help? So there are some retrospective studies which show that in 4 out of 10 patients, you can detect a primary on a PET. And out of these, lung was the most commonly detected primary. But remember, most of this data is 10 years old. Okay, in today's day and age, a PET this is probably not so relevant, I would say. Then when you look at patients with a favorable subsite, so remember 1 out of 5 patients or 20% of patients will have a favorable subsite of tumor. So what are these? These are adenocarcinoma in the axilla. So this is in women where you think of a breast primary. Peritoneal disease, so ascites and peritoneal carcinoma, people with probable ovarian or primary peritoneal carcinomatosis, a male with metastatic disease with a high PSA, extragonadal germ cell tumors, any tumor which just has a single site of disease. Squamous cell in the head and neck, squamous cell in inguinal, and neuroendocrine tumors. Now, why is this important? Because patients with a favorable subsite of disease have a better prognosis because you have access to site-specific treatment and they are localized. This is just very briefly about treatment. So I will just tell you what you need to remember is when you have adenocarcinoma in a male with, say, a PSA stain, you treat them like metastatic prostate cancer. You would give them androgen deprivation therapy and also other treatments like docetaxel and abiraterone and so on. In women with axillary nodes, breast primary, treat them along the lines of breast cancer. If you have, say, peritoneal disease, it's the same thing. So remember, in women with axillary disease, you have to do immunohistochemistry for ER, PR, and HER2/neu. And as a part of a metastatic workup, you can also get a MRI breast and a PET CT done. So in these women, if they only have axillary lymph nodes, you actually treat them with a curative intent. You treat them with like a 2nd stage or a 3rd stage breast cancer. You may give them surgery. You may do radiation. You may put them on adjuvant chemo or hormone treatment. And if they have other metastatic sites, you would treat them as metastatic breast cancer. And that is where it is relevant for us to know the hormone status and the HER2 status. So this is again one of our patients. So this is a 63-year-old lady whose daughter was a nurse, just 1 month history of bilateral axillary swelling. Her mammo was normal and she underwent an axillary lymph node biopsy, which showed an adenocarcinoma. Sorry, that is CK7, which is positive. That's a spelling mistake, and which was GATA3 positive. So automatically you know that this is a mammary origin tumor. She underwent an MRI breast, which was normal, and her IHC showed an ER/PR positive, HER2 negative tumor. She underwent a routine PET CT, which showed 2 brain lesions and also a lung nodule and multiple bone mets. So remember, the PET CT actually here is showing you the disease extent. It is not showing you the primary, it is showing you the disease extent. And that is very important for us because in this patient, had we not done the PET CT, we would have assumed that there is disease only in the axilla and we would have gone ahead and done a curative intent of treatment, which would not have benefited her. And she also had multiple bone mets. So she is being treated with, again, a newer drug called palbociclib and letrozole. She received radiation for the brain. She's actually in remission at 3 years. The other entity is, of course, squamous cell carcinoma. So in squamous cell carcinoma, So in squamous cell carcinoma, remember, if you have squamous cell carcinoma in the neck, in the lymph nodes, you would give them either chemo or chemo and radiation. And there are instances where we even do surgery to remove those lymph nodes, called like a neck lymph node dissection. Then these poorly differentiated tumors, again, when we look at which site they are from, that is what sort of directs our treatment along those lines. So I'll just look at, so when you have these specific for you in your ward, in your OPD, it is important to identify these subsites of good prognosis or good subset of patients to treat. So if you do have a man with osteoblastic bone mets, high PSA, go ahead, send him to urology, do your trust biopsy, and we will treat him as a metastatic prostate cancer. Then you have a young patient with tumors which are either he has multiple lung mets, very rapid symptoms, midline location, retroperitoneal mediastinal tumor. Please think of germ cell tumors, testicular cancer, send AFP, HCG and LDH. These patients have very chemo-responsive tumors. Even if they have brain mets, the treatment intent for them is curative. So this again is a patient who we treated. He was a 32-year-old male. He was an IT professional. He just came with 4 months of abdominal pain and he was found to have a retroperitoneal mass on CT. So he went to Bangalore, which was his hometown. He underwent a CT-guided biopsy, which only showed necrosis. And they evaluated him well. They did send cultures. And because of the necrosis, they started him on ATT, empirical, for 4 months. He continued to have worsening symptoms. And then he came here. The first 1522 is actually his LDH. And he had a very high HCG. So he had what was a retroperitoneal primary germ cell tumor. And so we did an ultrasound scrotum and there was some foci of calcification in the left testis. So we did an orchidectomy, but we didn't find any tumor. Now there are two possibilities for this. One, like I told you, could be a burnt out primary. Remember, his HCG is high. He could have been having a choriocarcinoma, which is burnt out. The other is he could have had a primary retroperitoneal tumor. So he did really well. He took his chemotherapy. He had a lymph node dissection and the retroperitoneal residual teratoma was removed and he's doing well. When you have, again, rare, sometimes when you have tumor in just one site, you can have these unusual primary tumors, some skin tumors, sarcoma, melanoma. Here, again, whole body PET CT is definitely indicated to rule out other sites. And when you have these aggressive histologies, you would embark on if you have a young and fit patient, you would offer aggressive local treatment. You would do surgery, resection, and plus or minus radiation and chemotherapy. So when you have squamous cell carcinoma in the neck, remember, if you have nodes, in majority, say 80 to 90% of patients, if you do a good evaluation, you will find a primary in the head and neck. In the remainder, most loco-regional therapy improves their outcomes. So loco-regional therapy is either radiation or surgery, okay? And sometimes remember, even if you do a surgery, after a surgery, you may end up finding a primary lymph node. In these patients, if they have low disease burden, we just send them directly for radiation and we give chemotherapy concurrent with radiation. If they have bulky big nodes, we give them what is called induction chemotherapy. Induction chemotherapy is essentially something which is sort of given to try and downstage it so that the radiation field becomes much smaller. And then, of course, we proceed and give them radiation. But remember, we treat them with a curative intent. Same thing with squamous cell carcinoma in the inguinal region. If there is no primary, similar logic, low disease burden, we would offer them an inguinal block dissection for plus or minus radiation and chemo. Bulky nodes, chemo followed by surgery plus or minus radiation. So this is again a patient who we very recently saw. This is a 52-year-old male. He's a smoker, 3 months of neck swelling. Initial lymph node biopsy was metastatic carcinoma, poorly differentiated. So in your mind, once you see this, you see a smoker with cervical nodes, in your mind, you know that this man could have a head and neck primary, he could have a lung primary, he could have an esophageal primary, and your IHC will go along those lines. So IHC CK56 is a squamous marker. EBV is, LMP1 is actually to look for EBV. And his NPL scopy was normal, but his PET CT showed a uptake in the fossa of Rosenmuller. This was actually biopsied, but it was negative for malignancy. So currently he's on his induction chemo because the nodes were slightly bulky, and we will reassess him with a PET scan after 3 months and then plan for chemoradiation. Remember, again, low-grade neuroendocrine tumors are, again, when you get a diagnosis of a low-grade neuroendocrine, when you see metastatic disease and you get this diagnosis, you're happy for the patient because these tumors are relatively indolent and can be treated like, you know, with things like octreotide, sunitinib, everolimus, and so on. And so this is actually a patient who we saw like a couple of days back. So this is a 46-year-old lady from Patna She had an acute diarrheal episode a month back, and she's currently well and asymptomatic. So her son just said, you have to go to the doctor. It's been so long since you went, just go and have a checkup. She did a routine ultrasound abdomen, which showed multiple liver mets. And so she was prognosticated and told she had a metastatic malignancy, and they came here. And our CT actually showed the classical arterial phase enhancement in the liver lesions. And that is very typical of a neuroendocrine tumor, not a carcinoma. And then there was also a nodal mass near the duodenum. We couldn't see a primary on the CT. So we biopsied the liver. It was a well-differentiated neuroendocrine tumor. And this lady is actually going to get a DOTA PET done, wherein we want to try and see where she has a primary. So this lady, even though she has metastatic disease, in neuroendocrine tumors, we try to treat them with a curative intent. And we will try and sequence treatments in the form of surgery, lutetium therapy, and also some systemic treatment options like I told you. High-grade neuroendocrine tumors are bad. They are the course is very fulminant. You treat them like small cell carcinoma lung with a platinum agent and etoposide. This is again a patient who's currently under us. He's a 37-year-old male. He's a lab tech and very young and fit person. Just 1 month of abdominal pain. Within a week, he goes on to develop jaundice and hepatic encephalopathy. And his ultrasound there showed multiple liver SOLs. He comes here, his CT shows a gastric mass with nodal, liver, and bone mets. And we did an endoscopic biopsy from the gastric lesion, which shows necrotic tissue. Now remember, highly proliferative tumors sometimes on your first biopsy will be necrotic. So that does not mean that there is no cancer. You will, and this patient, thankfully, despite having necrotic tissue, did have some tumor tissue wherein we managed to get his IHC done. So when you also see a radiological picture with disseminated disease and you get only necrosis, please repeat a biopsy. The patient should not be sent back saying, there is only necrosis, or should not be put on empirical treatment along the lines of an infection. So he was started on, his IHC was in favor of a high-grade neuroendocrine carcinoma of the stomach. So we started him on carboplatin and etoposide. Now, what about the rest? The unfavorable subsets, which nobody wants to treat. So again, remember, a lot of patients don't, like I told you, the favorable subset is only 20% of patients with a carcinoma of unknown primary. 80% of carcinomas true carcinomas of unknown primary don't fit into this, any subtypes. So this is again a girl who we saw a month back, a 22-year-old girl, a mother died of uterine cancer. So the ECOG is actually how we grade the performance status of our patients. Her performance status was 2. She was in a lot of pain. She had big cervical adenopathy with the right inguinal nodal mass, and that's her right lower limb edema. Her per-rectal examination showed a POD deposit. And the supraclavicular node showed a metastatic carcinoma, which was high. The MIB index actually shows you how fast your tumors are proliferating, which was 90%. And it had some neuroendocrine markers, the CD56 and synaptophysin was positive. So the next step in this girl would be to do the cross-sectional imaging. They had money issues for a PET. So we did a CT, which showed a large parietic nodal mass, which is actually compressing her common iliacs, ureter. There was this thickening in the upper rectum. There were mediastinal nodes, multiple lung mets. Her tumor markers we did for completion's sake were all normal. So, this is a patient who has this poorly differentiated carcinoma of unknown primary where you don't have a definite probable primary subset. So these are the really frustrating ones to handle because, the prognosis, they do much worse than patients wherein you have a favorable subset. And among these patients, some of the prognostic factors that we look at are the performance status, the younger the age, females, non-smokers, LDH just indicates their disease burden, albumin, and so on. So in terms of, in these patients, we just give empirical chemotherapy. There are 2-3 chemo drugs which are approved. Commonly what we use is we use a platinum and a taxane or a platinum and gemcitabine. The response rates are anything from 20 to 40%. And these patients with their metastatic disease, their median lifetimes, their overall survival is only around 6 to 10 months at the maximum. Now, there is a new concept, which I think all of you should know, is something called tumor agnostic treatment. So remember, even if you have metastatic disease, you can send for newer tests. So one of these, something which is interesting, is called microsatellite instability. So remember, if you have a tumor which is MSI high these patients benefit from immunotherapy, and the drug called pembrolizumab is actually approved. This is a tumor agnostic indication where, irrespective of where your tumor is from, if you have an MSI high tumor, you can treat them with pembrolizumab. Similarly, there is again a new kid on the block, something called NTRK fusions in this NTRK gene. So these are most commonly seen in tumors which are mesenchymal in origin, mostly in sarcomas. There are a few subsets or GIST and things like that. So there are some lung cancers also wherein this is seen. And there are 2 new drugs which are available, larotrectinib and entrectinib. So then what about next generation sequencing? So next generation sequencing, what are you doing? You're taking your biopsy and you're sequencing it and looking for targetable mutations. So this is definitely indicated in patients with what is called a true unknown primary tumor, like the girl who I just discussed, wherein we were very unsure about where her primary is. So how does it help? It will help you identify mutations which may be sort of directing you towards where the primary is. It will also help you identify targetable mutations, but remember that is only in around 10% of patients. So you should not get your hopes too high doing this expensive test saying, oh, I'm going to find mutations which I can target, because this is not the West. In the West, some of these rare mutations, patients may be having clinical trials in which they can take part. But remember, in our setting, the cheapest next generation sequencing costs as high as 30,000-40,000, which may not be accessible to most patients who come to our center. So to summarize, so when you have a patient who comes to you clinically, remember the first thing is what is very, very important, your clinical and pathological evaluation. So I cannot stress enough on that, okay? And then when you do that, your IHC, then your imaging, all that will fall into place. And remember, in today's day and age, not finding an anatomical primary is actually very, very rare. So if you find that primary site, very good, you will offer site-specific treatment. If you don't find a primary on your evaluation, you look at, can you fit these patients into any particular favorable subset, like I explained to you, and you treat accordingly, okay? So this is my last slide. So the take-home messages, again, importance of a thorough and complete history and physical examination followed by a biopsy, and importance of your IHC. And remember, you will learn to use the IHC to correlate the site of origin, and then identify patients with good prognostic factors. Don't send away a lady with an axillary lymph node which shows adenocarcinoma without evaluating the breast. Don't tell her you have cancer, go home. That is the end of the story. And then, of course, the importance of identifying patients with favorable subsets. So it is okay even if you have a 50-year-old male with cervical nodes which has squamous cell carcinoma and you don't find a primary, this patient can be treated. Then also it is important, the other thing is important, to identify those patients who have an unfavorable type of tumor, and then it is important to prognosticate them well in advance about their poor prognosis, low overall survival, early incorporation of palliative care. And then remember the newer treatments like molecular profiling, next generation sequencing, and of course, tumor agnostic treatments. Okay, so I'll stop here. I can't see any questions. Okay.
Thanks a lot, ma'am. I think there is quite an end to our series of sections on medical oncology. I think this kind of very well covered whatever I think we kind of face on a day-to-day basis. If any questions, please put down in the chat box. Meanwhile, I think, ma'am, we just highlighted quite a lot on the fact that doing a PET CT in terms of not just searching for a metastatic, not just for searching for a primary, but in terms of finding out for the metastatic lesions, than just saying that it's just a primary and treating that, ending up finding somewhere else to treat for, like giving a whole brain RT, but make it in a curative and then ending up in a palliative mode. I think people can understand what's been told in that sense. And also the necrotic part, I think quite a lot of us have a tendency to have this kind of people, at least, okay, it might be correct in the sense that we do manage with an empirical ATT, but then if at least not responding, and then had a patient who had an highly proliferative lesion, had a necrotic lesion, to re-image or a re-biopsy.
So I mean, just to sort of add to what Anju's pointing out, if you have a radiological picture, which is very, very suspicious and very typical, and you have only necrosis, please re-biopsy. Or if at all the patient wants to go home for any reason. I mean, a lot of our patients actually come from other places, right? But then it is important that the patient understands that, you know, he needs to come back at 2 months. So often what happens is they get lost and then they come back by the time, you know, that is a...
On that note, so if you're saying that when you have an unknown primary and then, or if when you are treating the patient, re-evaluating in terms of when we have treated off on an empirical basis for a malignancy, the re-imaging will be on a, how often, like for a primary?
So any metastatic cancer, often we try and image them anything in a frequency of, say, at least every 3 to 4 months is what is ideal. But remember, what is ideal and what is in practice is often totally poles apart. So we try and image them at least once in 4 to 6 months. And of course, at any point, if there is a clinical worsening, that is a good point to re-image. And one more thing, which I probably didn't mention during the talk, is that, see, just because you don't identify a primary at your initial evaluation, it is okay. Because this patient, even after you treat, subsequently you will keep doing your scans, and something may come up. And we've had instances where, you know, we've actually changed the diagnosis. Okay, so the diagnosis has been, but that's very rare in a setting of a tertiary center. That's very rare, but that too can happen. So that's the importance of the repeat imaging as well.
And any further questions? Doing this panel of IHCs, molecular assays, and other things, it's only in a tissue profiling, or in the metastatic status, do we have this? I mean, we do testings on a blood.
Okay, so that's a great question. So that is something called a liquid biopsy. I think you may all have heard of this thing called a liquid biopsy. So a liquid biopsy essentially tries to, what you're trying to do in a liquid biopsy is you take the patient's blood and you look for there are 2 tests. One is to look at cell-free DNA and you look at circulating tumor cells. And what you would want to do is that, like how in a normal next generation sequencing, you are taking the patient's tissue and looking for mutations, you are trying to isolate this DNA, or you're trying to isolate the tumor cells and do the same test in that. Okay. So now again, liquid biopsy, not yet really too accessible too much to our patients, but it's a great thing. So if for any reason, like there are patients wherein, you know, you diagnose cancer and the primary tumor isn't really accessible well, and you may just have, say, only an FNAC from there, and you don't have tissue. In those patients, a liquid biopsy and NGS is definitely acceptable, yes.
Sure. I think, if no further questions, we can wind up. This lecture will soon be uploaded anyways in our Department of Medicine YouTube website. Thanks again, ma'am. I think that was a very wonderful session on approach to unknown primary. I think you all might benefit. Sure, thanks a lot, ma'am.
Okay, thanks.